The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with a discussion of another one of our very interesting papers that's just appeared in JACC. In this particular case, I'm talking to Dr. Stephen Nichols, who's assistant professor of molecular medicine and the director of the Atheroscl laboratory at the Cleveland Clinic. And Dr. Nichols has just authored a really interesting paper examining the relative effects of a lowering of LDL cholesterol and blood pressure and their effect on the regression or lack of progression of plaques. Tell me, Dr. Nichols, what stimulated you to look at the combination of blood pressure and LDL cholesterol?
Well, Dr. DeMaria, as you know, we've now used serial intravascular ultrasound, or IVUS, in a large number of clinical trials to evaluate the effects of medical therapies on the progression of coronary atherosclerosis. And what we've really learned in those studies is that therapies that target established risk factors such as LDL cholesterol and blood pressure in particular appear to have a beneficial effect in slowing disease progression. So we were very interested in the concept of looking at whether there was an incremental benefit of intensive lowering of both of those risk factors, with this concept of global risk being particularly important for the patient with CAD.
Yeah, one would have predicted that they would be mutually beneficial. How did you go about showing that?
So what we did was we pooled 7 of our clinical trials involving nearly 3,500 patients, all with angiographic CAD, who underwent serial intravascular ultrasound in our studies. And we stratified patients according to their achieved on-treatment levels of both LDL cholesterol above or below 70 milligrams per deciliter, and a systolic blood pressure of above or below 120 millimeters of mercury. So we essentially had 4 treatment groups that we compared the progression of disease, and we, in particular, we looked at the changes in the percent atheroma volume, the PAV, and the total atheroma volume, the TAV.
Yeah, and I know from your results that clearly blood pressure and LDL cholesterol do have an association.
What we basically see is that if both of those parameters are higher, i.e. an LDL greater than 70 and a systolic blood pressure greater than 120, they are the patients who have the most progression of disease. As you lower one of those parameters below 70 or less than 120, you get a reduction in disease progression. And it became quite clear to us that the patients who have the least progression of disease in their coronaries are the patients who get both their LDL below 70 and their systolic blood pressure below 120. So it very nicely reinforced the concept to us that it was intensive management of global risk, trying to hit multiple risk factors, that was going to have potentially the greatest benefit for patients.
Yeah, could you determine whether LDL or blood pressure was more effective?
It did look like LDL was more effective. It looked like you had a bigger bang for your buck by getting your LDL below 70 than getting your blood pressure below 120. And in other words, you know, the incremental benefit of taking a patient who already had an LDL below 70 and then getting their blood pressure below 120 was less than the opposite.
Well, I'm convinced. I'm keeping my LDL below 70 and my systolic blood pressure less than 120, and hopefully I'm going to eliminate the progression if I have any plaques. Thanks very much for being with us.
Thank you. Pleasure to be here.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.